Welcome back to the deep dive. Usually when we grab a stack of research, we're looking at these huge global topics. AI, the economy, history.
I'm looking at the forest, right?
Exactly. But today we are zooming way in. I mean, we are getting microscopically close to one very specific, very strange part of the human body.
It's a real shift in perspective. Today, we are absolutely looking at a single fascinating tree.
We are looking at a lump on the side of the face, specifically the parotid gland. And our source material is this clinical guide on parotid swelling. And I have to be honest, when I first saw the title, I thought, okay, this is gonna be dry.
For med students cramming for an exam.
Right, but it's not. It reads like a detective novel.
It really does. It frames the doctor not as, a technician, but as an investigator. And the stakes are incredibly high.
That's the hook. The whole medical detective idea, not the TV version with the dramatic music.
No sprinting down hallways.
No, we're talking Sherlock Holmes, the quiet, observant kind of deduction where the answer isn't in some $1 million machine, but in a simple conversation.
And that is the core premise of this entire guide. We live in this age of MRIs, PT scans, you name it. But this guide reminds us that 90% of the diagnosis, figuring out if that lump is a harmless stone or a life-threatening cancer, it happens before you even touch the patient.
Just by asking the right questions.
Exactly.
So that's our mission today. We're going to deconstruct this guide, which is brilliantly set up as the wrong way versus the right way to interview someone. It's a masterclass in how to stop asking lazy questions and start asking life-saving ones.
It really highlights the difference between gathering data and gathering insight. The lazy questions, they just fill out a form. The right ones unlock the mystery.
Okay, so let's unpack this. Let's start at the very beginning. The guide calls it the setup. And the wrong way is just asking, where do you live?
Standard admin stuff.
Yeah.
It's for billing. It tells you nothing about the pathology inside the patient's face.
So what's the right way? Why does a person's job matter for a lump in their jaw? The guide specifically flags woodwind musicians and glassblowers.
It sounds so random, doesn't it? But it all comes down to physics. Think about a glassblower, or say a clarinet player. What are they physically doing?
They're blowing air.
Immense intraoral pressure. Exactly.
Yeah.
They're forcing air out against resistance. Now, the parotid gland has this little tube, a duct, that empties saliva into the mouth.
Right.
If you spend years generating that high pressure, you can actually force air or even saliva backward up that duct.
Wait, really? You're literally inflating the gland from the inside out.
Essentially, yes. It's a condition called pneumoparotidis. You're blowing air into the gland, causing the duct to widen. It just creates an environment that's prone to infection and swelling.
Yeah.
So if you just write musician on a form, you miss it completely.
That's the kind of physics I had never considered. And what about geography? The guide insists on asking where someone is from, not just where they live now.
This is critical. In the Western world, we don't see a lot of tuberculosis in the neck. But in many parts of the world, TB is endemic. And the tricky part is, TB loves lymph nodes.
And I'm guessing there are lymph nodes inside the parotid gland.
A bunch of them. The gland encapsulates them. So if a patient from a TB endemic region has a lump, it might not be a tumor, it could be a TB infection. And if you don't ask that question, you go to surgery.
And what happens?
You can cause what's called a draining sinus. The wound just refuses to heal, it leaks. You've turned a manageable infection into a surgical nightmare,
Yeah.
all because you didn't ask about their childhood home.
Wow. Okay, let's move to the lump itself. The guide uses this mnemonic, scotame, sight, color, tenderness. The wrong way is just show me where it hurts.
Too vague. You have to define the territory. The parotid has a specific footprint, it's preauricular right in front of the ear, and it extends down to the angle of the jaw. But the critical distinction is it on one side or both?
Unilateral versus bilateral.
This is your first major fork in the road. If the swelling is unilateral, just one cheek, you're thinking about a mechanical issue, a stone, a tumor, something in one spot.
Okay, one blockage, one lump. Makes sense.
But if it's bilateral, if the patient looks like a hamster, that is almost never a tumor.
Why not?
Tumors rarely strike the same spot on both sides at the same time. Bilateral swelling tells you the whole system is reacting to something.
So the body's fighting a war on two fronts.
Exactly. Could be
Yeah.
mumps, could be an autoimmune condition like Sjogren's syndrome. You're looking for a systemic cause, not a local one.
There's a detail here that honestly gave me the creeps. The deep lobe check. The guide says you have to ask if they feel a lump inside their mouth.
That's a pro tip that gets missed so often. The parotid isn't just a flat pancake on your cheek, it's shaped more like a dumbbell. There's a superficial lobe you feel on your face, but also a deep lobe that wraps around the back of your jawbone.
So it's like an iceberg.
Perfect analogy. You might see nothing on the outside, but a tumor in that deep lobe has nowhere to go but inward. It pushes into the throat. So asking, when you run your tongue along your cheek, do you feel a lump, can reveal a tumor that's otherwise invisible.
Terrifying. Okay, moving on to the timeline. The guide makes a huge deal about speed.
Speed tells a story. And in pathology, speed usually kills. The wrong way is just asking, how long have you had it?
And the right way is establishing the rate of acceleration, so fast is bad.
Usually. If a lump appears in days or weeks, it's angry, it's an infection, or maybe a very aggressive malignancy.
Yeah.
Fast cell division equals fast growth.
And slow is
That's
good.
generally, yeah. If a patient says, oh, I've had that bump for 6 years, everyone in the room sort of breathes a sigh of relief. That pattern is classic for a benign tumor, like a pleomorphic adenoma. It's growing, but it's not in a rush.
But then we get to consistency, and I laughed at the wrong way for this one. The doctor asks, is it soft? And the patient's like, I don't know, maybe.
Patients aren't pathologists. Soft is totally subjective. You have to give them a reference point.
The guide suggests asking, does it feel like your lips, the tip of your nose, or your forehead?
It's a brilliant little diagnostic hack. If it feels like your lips, it's likely cystic, fluid-filled. If it feels like the tip of your nose rubbery, firm, it's usually a benign tumor. But the forehead,
Has bone.
exactly. If the patient says it feels rock hard like their forehead, that is a major red flag for malignancy. Cancers tend to be hard, irregular, and fixed.
And that ties into mobility. Can you move it? The guide has a specific trick with clenching your teeth.
Yes, the clench test. The
Yeah.
parotid gland sits right on top of the masseter muscle, your big chewing muscle. If you ask the patient to clench their teeth, that muscle becomes a solid wall.
Okay.
Now, if the lump is just sitting on top, you should still be able to wiggle it around. But if it's an invasive cancer,
It grabs on.
it ignores boundaries, it grows into the muscle, so when they clench, the lump just locks in place. It's tethered. If you can't wiggle it, it suggests the disease is invasive.
Okay, so we've poked it, we've timed it. Now for my favorite part of this whole guide, the dinner table diagnostic. This connection between the lump and food just blew my mind.
This is the real aha moment in salivary diagnostics. It's what we call pathognomonic, a fancy way of saying, if you see this symptom, it's almost certainly this one disease.
And the question is, does the swelling get bigger or hurt when you eat? Or even just think about food?
It sounds like magic, but it's pure mechanics. You see a lemon, you smell a steak, your brain tells your parotid glands to fire, they start pumping out saliva.
Pavlov's dog.
Exactly. Now imagine you have a stone, a little calcified rock, blocking the exit duct. The gland tries to squeeze saliva out, but the door is locked.
It's hydraulic pressure inside your face.
Precisely. It's like stepping on a garden hose when the tap is on full blast. The gland swells up, and it causes intense pain right at mealtime.
And the guide gives the specific timing. Pain lasts 30 to 120 minutes after a meal. Why that window?
Because eventually, the saliva slowly leaks past the stone, or the gland just stops producing as much, and the pressure goes down. So if a patient says, "Doc, every time I sit down to dinner, my face hurts," you basically have your diagnosis. Xylophiasis. Stones.
It's amazing. But not all signals are about food. Some are much, much darker. The guide has a whole section on red flags, and the biggest one seems to be the nerves.
Right, this is where the tone shifts. We stop being curious and start being urgent. We have to talk about the facial
The
nerve.
wire that controls the face.
It controls your smile, closing your eyes, everything. And it runs right through the middle of the parotid gland. It's literally sandwiched inside it.
So if something goes wrong in the gland, the nerve is in the line of fire.
Benign tumors are polite. They push the nerve aside, they stretch it, but they almost never break it. Malignant tumors, though, they're invaders. They eat right into the nerve.
So the single most important red flag is facial weakness.
Yes. The guide lists the questions. Can you close your eye fully? Is your smile uneven? Does soup dribble out of the corner of your mouth?
And the guide states it so clearly. New onset facial paralysis with a parotid mass is malignancy until proven otherwise.
That is a heavy, heavy sentence. Malignancy until proven otherwise. It means you assume it's cancer, it changes everything.
Let's zoom out a bit. We're getting into the systemic stuff now. Segment 5 is all about Sjogren's syndrome. This is where the detective has to look at the whole person.
Correct. Sjogren's is an autoimmune condition. Your body's immune system gets confused and attacks its own moisture-producing glands. So, tears and saliva.
And your parotid glands swell up, usually on both sides, but the guide forces you to ask about the other moisture glands.
You have to screen for dryness. Do you have gritty, dry eyes? Do you have a dry mouth? But the problem is, patients get used to it. They don't always know they're dry.
So you can't just ask, you have to use the cracker sign.
The cracker sign. It sounds funny, but it's a valid clinical test. You ask the patient, can you eat a dry soda cracker without sipping water?
And if the answer is no,
It means their saliva flow rate is critically low. They can't lubricate the food to swallow it.
why is diagnosing Sjogren's so critical? Is it just about comfort, prescribing some artificial tears?
No, and this is the scary statistic the guide highlights. Patients with Sjogren's syndrome have a 40-fold increased risk of developing lymphoma, specifically multi-lymphoma within the gland.
40-fold. That is massive.
It's huge. The immune system is so overactive in that gland that eventually a cell goes rogue. So asking about dry eyes isn't just about quality of life, it's about cancer surveillance. You miss the Sjogren's, you might miss the lymphoma.
It really emphasizes how interconnected everything is. Which brings us to segment 6, lifestyle detective work. Drugs and habits.
The medication review is classic detective work. You look at their list. Are they on antihistamines, antidepressants, blood pressure meds?
The guide lists all of those. Why do they matter for a lump in the face?
Because of a concept called ascending infection.
Which sounds incredibly unpleasant.
It is. Saliva is a flushing mechanism. It washes bacteria out of the duct. If you take meds that dry out the mouth, you lose that flush.
And the bacteria move in.
They crawl up the duct. From the dirty mouth into the clean gland. So the lump can just be a bacterial infection caused by a side effect of a pill.
And then there's the smoking gun, literally.
Smoking is tied to a very specific type of benign tumor called a Warthin's tumor. It's almost exclusive to smokers. The guide says you have to quantify it. Ask about pack years.
So if you see a lump, both sides, older guy, smoked for 40 years.
Warthin's tumor moves to the very top of your list. It's a smoker's badge, practically.
And trauma. I mean, getting hit in the face is obvious, but the guide mentions biopsies.
Iatrogenic injury caused by doctors. If someone had a prior surgery, they could have scar tissue or a cyst. You have to ask about the history of that specific patch of skin.
Okay, so we asked a million questions. We know if they play the flute, if they can eat a cracker. What do we actually do with all this info?
Once you have the history, you need confirmation. The roadmap is very clear. Step 1 is almost always ultrasound.
I'm surprised it wasn't a CT scan.
CTs have radiation. And for soft tissue in the neck, ultrasound is cheap, harmless, and it tells you the most important thing. Is this solid or is it fluid?
If it's fluid, it's a cyst or an abscess.
Right, you can drain it. But if it's solid,
Then you need cells.
FNAC, fine needle aspiration cytology. You stick a tiny needle in, get some cells, look at them under a microscope. It's about 85 to 90% accurate.
The guide says MRI is the gold standard, but only for certain things.
You don't MRI everyone. You use it if you suspect malignancy. Maybe they had that facial nerve weakness, or if the tumor's in that deep lobe we mentioned. MRI gives you that beautiful soft tissue detail.
And finally, treatment. It seems like surgery is the main answer for tumors, but the guide mentions some pretty specific risks.
For a benign tumor, yes, you cut it out. The big fear is always facial nerve weakness. But there's also something called Frey's syndrome.
Frey's syndrome. The guide calls this gustatory sweating, which just sounds weird.
It is bizarre. It's a rewiring of the nerves. When you remove the gland, you cut the tiny nerves that used to tell it to make saliva. As they heal, they get confused.
And what do they find to connect to?
The sweat glands in the skin of your cheek. So in the future, when you sit down to eat, your brain sends the signal, salivate, but the wire goes to the skin. And instead of drooling
Your cheeks start sweating.
profusely, it's socially awkward to say the least, but it's a known complication.
That is unfortunate, but better than leaving a tumor in there.
Absolutely. And for scones, the treatment's so much better now. We have silent endoscopy,
Like a video game for your face.
basically.
Yeah.
Microscopic camera goes up the duct, we find the stone, and pull it out with a tiny wire basket. No cutting required.
It's amazing, but it brings us right back to where we started. All that technology doesn't matter if you didn't ask the right questions in the first place.
That's the ultimate takeaway. You can have the best MRI in the world, but if you didn't ask about mealtime pain, you might be looking for a cancer that isn't there. If you didn't ask about dry eyes, you're missing a systemic disease.
So let's recap the right way. What are the big 3 takeaways?
First, specificity. Don't ask, does it hurt? Ask, does it hurt when you eat? Context is everything.
Right.
Second, red flags. Facial nerve paralysis is the siren that screams cancer. Malignancy until proven otherwise.
And third,
The systemic link. Never look at the gland in isolation. Dry eyes and dry mouth point to Sjogren's, which carries that massive lymphoma risk. The gland is just a mirror for the rest of the body.
it's a powerful reminder of how the body is one interconnected machine. And here's a final thought to leave you with. We tend to ignore the little things, a dry mouth, a little sweating when we eat. But in the world of the medical detective, those tiny annoyances are actually loud, clear signals. It makes you wonder, what else is your body trying to tell you right now that you're just not listening to?
A great question. Listening's the best diagnostic tool we have.
Thanks for joining us on this deep dive. Stay curious, keep asking questions, and we'll see you next time.